These are the goals that sort of would come out if we looked at inhaled amikacin, the ability to predict activity against MAC, look at some MICs before and after therapy and see if they're different. That is, if you fail therapy, the MIC is the smallest amount of concentration that inhibits the growth of the organism. Does that change when you treat a patient and you fail? That failure can be associated with mutations that are specific for the activity of the drug. It may be the site where the drug binds within the cell. That's true for amikacin, where the binding site is the protein building, translating area of the cell. Amikacin binds to that, and if you have a mutation in that area, it no longer binds and it no longer works. And then trying to figure out what kind of concentrations work. One of the issues would be, for example, we know what kind of levels we can achieve in patients above which we get into trouble with toxicity. We really have no idea about inhaled medicine. There are several inhaled medicines that are used for Pseudomonas. Many of you are familiar with that. Inhaled tobramycin, the most common. There are no sensitivities or markings of susceptibility or resistance for Pseudomonas for inhaled therapy. So when somebody says, well, my report says that my Pseudomonas is resistant to amikacin, that applies only to intravenous therapy. We really don't know. And for the newer drugs, the same thing. There are none of them that the FDA has decided to take on or accept the break point that would tell you whether those drugs work or not. Dr. Olivier will tell you that I was never a supporter of inhaled amikacin, not because I didn't think it wouldn't work, but because there was no science behind it. There was a single paper of, I think, 5 patients that was published with essentially no laboratory values, no reports other than saying basically that it worked in some number of patients. 9.5 years later, we don't have any more publications. Is it safe? It doesn't get very high blood levels when you inhale it, but still, in an 80-year-old woman, maybe that's enough to make her lose her hearing, to affect her kidneys. We just don't have any safety data, but we're all using it. But I was very negative about using it. Then this lady came along. This lady had MAC lung disease. She was resistant to clarithromycin. She had failed more than 5 years worth of therapy. She was not a candidate for resectional surgery that Mike talked about because she had bilateral disease. She had not had amikacin before, and I wanted to give it to her. She refused. She says, I'll inhale it, but you're not giving that to me IV. She's smart, like many of you ladies, smart, intelligent lady, so I gave in. This is a summary of the course of this lady. These markers tell you how much growth there was of MAC on the culture plates. 4+ is the most you'll ever see. That means there's no blank spaces on the agar plate when you look at the growth. It comes down, down. Less than 50 colonies is a very tiny amount of growth for the most part. So the difference between less than 50 colonies and 4+ is about 50,000 colonies. It's an enormous drop in terms of what's there. And NG means we didn't grow anything on the agar and nothing in the broth. This lady, again, had been followed for a fairly long period of time. Most of her cultures were in the 3+ to 4+ range. We tested that for known mutations of the ribosome to amikacin and could not detect any. The MIC for her isolate is 8. Now, it doesn't mean much to you, but that's a pretty low number for amikacin. It's a typical MIC, for example, for Pseudomonas. It's a typical MIC for Mycobacterium abscessus, organisms that we know respond to amikacin when given systemically. Again, it was tested for mutation. The lady had been on these other drugs again for 5 years. At that point, she was started on inhaled amikacin, 500 milligrams once daily, and remained on her other drugs. And this is what happened to her cultures. She went down to less than 50 colonies after, I hadn't seen that few colonies in her since way back in the early days of her disease. She actually had one that was no growth. And then she had another one that was less than 50 colonies. This is a lady that just massive amounts of MAC grow on her plate every time I test it. We don't test her that often because there's no point in doing it. She then, after being on these drugs about 5 months, went from less than 50 colonies to 4+ again. When we looked at her MIC, that is the amount of drug to inhibit her growth, which had required only 8 to 16 originally, it was now greater than the highest concentration that we tested. That is, there was no difference in any of the wells that contained antibiotics in terms of the amount of growth. It grew just as well as it did in the control plate with no drug in it. When we sequenced the areas of the ribosome that we know are associated with amikacin resistance, her isolate had a mutation in the classic place where we see resistance to amikacin with tuberculosis, Mycobacterium abscessus, the main areas that we tend to use amikacin. Her culture stayed at the same place. We tested her again a couple of months later. Same MIC, same mutation. Now, having said that, I will tell you that she had a CT done here, and it was dramatically better compared to the CT that was taken before she started her amikacin. And despite the microbiologic relapse, that is, she's growing lots of colonies, she stayed really well for her and still is really well compared to the normal state for her. When I looked at all this, first of all, I didn't expect amikacin to work that well. And second of all, I had not thought about the development of drug resistance in amikacin as being an inhibition to the efficacy of drugs, because we don't do this kind of testing. Now, remembering that this is inhaled amikacin, it suggests that this mutation will inhibit any activity from inhaled amikacin, presuming the dose is, she was on a pretty good sized dose. We don't know the dose, for example, with ARIKAYCE. It's a different kind of administration. It requires different transport systems into the cell. It may be that the concentrations are high enough that they will overcome this single mutation, but at least the way we were given it, it didn't make any difference. I was shocked and impressed. The next case that I'm going to tell you about involves Mycobacterium simiae. Unless you're from Texas, you've never heard of this organism, but it's highly endemic in the US. In Texas, it comes from large aquifers. It's not in surface water. So San Antonio, for example, is the epicenter of M. simiae, and we get a moderate number of those patients. Although the isolate is susceptible to macrolides, it has been incurable with drugs. We have not made anybody negative. Now, we've made patients better, but like regular M. abscessus, we rarely, if ever, cure those patients. Enter this 83-year-old Hispanic female with nodular lung disease, and her problem was recurrent massive hemoptysis. She had undergone special clotting of the pulmonary arteries that we thought were bleeding. She'd undergone it 3 times. It helped her temporarily, and then she started bleeding again. I put her, she was sent to me as sort of last ditch, and this is when I saw her, which is in November of 2010. We started her on some medicine. She actually was quasi-susceptible to 2 or 3 drugs. And she remained on those drugs here for a year. Interestingly, at this point, she was better, had no more bleeding, and her CT was better. But we really hadn't affected her cultures at all. She's very frail, not a candidate for IV amikacin, so we added inhaled amikacin. Only medicine we added to what was a very stable sort of culture. This is what happened. She went down to less than 50 colonies, and she remained there. And on her last sputum, she is negative, the first negative I have ever had on this lady since I've been following her. I'm impressed. Now, this doesn't constitute a clinical trial, this doesn't, but it sure makes me, because this is the disease for which, and I don't think she'll stay negative. But she's had a good quality of life. I'm not sure why she hasn't bled during that time period, but she is happy as a clam. So we then said, well, let's look at what kind of concentrations of amikacin are required to inhibit MAC. Both of these were relatively low. Maybe that's just a freak in the sense that most of them are very high. Well, it turns out when we looked using standard testing mechanisms that are recommended for all laboratories for testing NTM drugs, half of these isolates had MICs of 8, which again for amikacin is a relatively low value. 90% of them were inhibited by 16 or less. I know the number doesn't mean anything to you. That's still a low number for amikacin. It is certainly a low number for inhaled amikacin. Interesting enough, 2% of the isolates, now this was just the first 500 that came into the lab, had MICs of 64, done twice, exactly like we described before. Absolutely no drop in growth at all. Looking at each of these wells, that contains a 2-fold increase in the drug. So the last one has 64. It looked exactly like the well with no antibiotic in it, just grew just as well. All of those turned out to have the same 16S ribosomal mutation as we saw in the others. We were able to obtain good histories in 5 of those patients. All had been on prolonged drug therapy, including amikacin, both inhaled and IV, and some had been on it essentially as monotherapy. Interesting, 5 of the 7 patients were macrolide resistant. They were Biaxin resistant. That is a relatively rare event in MAC these days. It is also the main drug that is likely to support or protect amikacin against the development of drug resistance. So these were the high-risk patients. Bad disease, poor response to other drugs. The main drug to protect them is no longer available. And I might note that for clarithromycin, failure of the drug and rise in concentrations of drug to inhibit the organism is associated with a mutation in a very similar place in the ribosome.